Good morning, everyone, and welcome. My name is Eleni Moulis. I am a physical therapist from Boston Children's Hospital, and I am one of the physical therapists for the young adults unit, which is a collaboration between Boston Children's Hospital and Brigham and Women's Hospital. And I'd like to introduce my co-chair, John Lohman. He is from the University of Alabama at Birmingham. And today we will be monitoring a very interesting course for you. It's PT, Physical Therapy and Respiratory Therapy Research, Updates and Care. We have no disclosures, and this session will review the latest evidence regarding exercise in people with cystic fibrosis. 4 accepted abstracts will be presented to facilitate knowledge translation of exercise, assessment, testing, and intervention to the CFPT community, including time for open discussions and questions. Our objectives: to discuss the impact of exercise testing in a post-highly effective modulator therapy era, to describe the impact of exercise prescription in highly effective modulator therapy era, and to compare and contrast different methods of exercise testing in people with cystic fibrosis. And at this time, I'd like to introduce to you Dr. Lohman.
Yes, thank you for everybody for being here. So first up, we've got a great panelist today. Some are experienced presenters, some are presenting here for the first time. And first up, we'd like to ask Dr. Julien Perron, hopefully I pronounced that right, pulmonologist from France, who'll be talking on the 6-minute walk test kind of in the post-modulator era.
Hi everyone, my name is Julien Perron. I'm currently working in a CF center at the Hospice Civil of Lyon in France. I'm really happy and honored to be here to present my medical thesis that I defended last week, change in the 6-minute walk test among 71 patients with cystic fibrosis treated with ETI. I have no relationships to disclose in connection with this presentation. So, exercise intolerance is a hallmark of cystic fibrosis, impacted both quality of life and prognosis. To date, few studies have evaluated the effect of CFTR modulator therapy on exercise tolerance. The pathogenesis is multifactorial and involves a combination of central and peripheral factors. They are directly linked to CFTR abnormalities expressed in myocardial cells, vascular smooth muscle, and skeletal muscle. Other factors can contribute to low exercise capacity: deconditioning associated with low physical activity, chronic inflammation, and reduced lean muscle mass associated with poor nutritional status. The 6-minute walk test is a standardized method to assess exercise capacity in patients with chronic respiratory disease, including people with cystic fibrosis. The perspectives on exercise tolerance have changed with the advent of modulator therapies. Previous research on both first and second generation treatments have shown conflicting results. Only few retrospective studies have evaluated the effect of ETI on the 6-minute walk test. Most studies that have investigated the clinical properties of the walk test in cystic fibrosis were conducted many years ago, before the advent of CFTR modulators. We wanted to reassess its utility in the current context. Our research focused on changes in exercise capacity induced by ETI in people with cystic fibrosis. Our initial hypothesis was that ETI can improve exercise capacity by reducing hyperinflation, which is a potential mechanism limiting exercise tolerance. The main objective of the study was to compare the 6-minute walk distance before and after ETI initiation. Secondary objectives were to compare the 6-minute walk test, the other variables of the 6-minute walk test, to compare quality of life and pulmonary function tests at 12 months, and last but not least, to explore correlations between changes in 6-minute walk test and changes in pulmonary function test results. We conducted a retrospective cohort study in our regional CF center in France. Inclusion criteria were people with cystic fibrosis, homo or heterozygous for the F508del mutation, age of at least 12 years old, who started ETI between March 2020 and September 2022. People have to perform the 6-minute walk test within the first 12 months before ETI initiation and after 14 months. Moving on to the study design. We collected the best 6-minute walk test defined as the greatest distance performed within the first 12 months before ETI initiation and again during the first 14 months of treatment. Pulmonary function tests, including spirometry and plethysmography, were performed on the day of ETI initiation and during the follow-up at 12 months. Cystic fibrosis questionnaire revised was also performed at these 2 time points. We evaluated 2 specific domains of quality of life, the physical score and the respiratory score. The primary endpoint was the 6-minute walk distance. We decided to perform a subgroup analysis before conducting the study. Subgroups were based on FEV1, history of previous modulator therapy, and age. We compared data at baseline after treatment using Wilcoxon sign rank test and adjusted p-value for multiple comparisons. We calculated Pearson coefficient correlation coefficients to assess relationships between the variables of interest, considering a p-value below 0.05 statistically significant. Among 113 patients treated with ETI in our center, 83 were eligible and 71 patients were included in the study. You can see on the right-hand side of this slide the number of patients excluded and the reasons. You can see on this slide the main patient characteristics at the time of ETI initiation. 68% were male with a median age of 33 years old. 51% were homozygous for the F508del mutation, and 86% were colonized with Pseudomonas aeruginosa. The median FEV1 was 58%. 19 patients had a baseline FEV1 less than 40%. 55% of patients had previously received modulator therapies, mainly the lumacaftor-ivacaftor combination. 6-minute walk test was performed at a median of 356 days after ETI initiation. The mean baseline walking distance was 641 meters, representing 89% of the predicted value. The primary outcome of the study was a significant increase in walking distance by 16 meters after ETI. Patients with an FEV1 less than 40% increased their walking distance by 38 meters. Those who were not previously treated with modulators improved by 22 meters, while patients over 18 years old increased their distance by 20 meters. This waterfall plot shows the individual change in 6-minute walk distance. The 3 categories of FEV1 are shown, in red for less than 40%, in orange from 40 to 90%, and in green for over 90%. You can see that 68% of the patients improved their walking distance after ETI, while 22 patients showed a decline. It clearly shows a significant improvement in walking distance among patients with severe respiratory impairment represented in red. You can see the changes in other 6-minute walk test variables. As expected and shown in the two top diagrams, the mean and the minimum oxygen saturation increased, related to improved respiratory function. Higher heart rate following ETI reflected an increased exercise intensity. End-test dyspnea showed minimal change following treatment. Median dyspnea was low at baseline with a median score of 4.5, suggesting that ventilatory limitation was not the primary cause of exercise intolerance in our study population. After 12 months, we observed a significant improvement in quality of life with an increase of nearly 18 points for the physical score and 27 points for the respiratory score. After 12 months, FEV1 increased significantly by 15.8%. We can see that the greatest improvement happened for patients with FEV1 less than 40%, with an increase of 17.8%. Static hyperinflation markers were reduced after 12 months. This suggested a thoracic hyperinflation reduction. And we found no correlation between changes in pulmonary function test results and changes in 6-minute walk test results. So our study confirmed a significant improvement in 6-minute walking distance after ETI. This result is consistent with previous retrospective study. The strength of our study is that it included a larger number of patients than all other studies, increasing the statistical power. The walking distance improvement was smaller in our study, likely due to a greater heterogeneity of our population, which was not limited to patients with severe lung disease. Our study result can be also explained by a ceiling effect. The baseline walking distances were high in our study, making it more challenging to detect further significant improvement. Also statistically significant, the improvement in walking distance fell below the minimal important difference usually reported from 25 to 33 meters in chronic respiratory disease. However, we consider this improvement clinically relevant given the dramatic increase in the CFQR physical score. The main strength of our study is to have access, quality of life that directly reflects benefits experienced by patients. The greatest improvement occurred in patients with severe lung disease. They also experienced the greatest improvement in FEV1, indicating that the improvement in exercise capacity is likely due to improved pulmonary function. Another strength is to have analyzed all 6-minute walk test variables. We found it important to evaluate changes in static lung volumes, as hyperinflation is a potential factor limiting ventilation during exercise. In terms of potential limitation, we conducted a monocentric study. The retrospective design introduced variability in the timing of the 6-minute walk test conducted under ETI. There was a lack of control group as most patients were treated with ETI in our center, and missing data may have impacted our results. For example, patients colonized with Burkholderia cepacia underwent only spirometry without plethysmography. And the small number size of children also limits the generalizability of the findings. To conclude, ETI improved exercise capacity within 14 months after treatment initiation, as showed by a significant increase in 6-minute walk distance in our study. This improvement occurred independently of any rehabilitation program and was greatest in patients with severe lung disease. ETI was also associated with an improvement in quality of life, specifically in the physical domain. and changes in pulmonary function cannot predict changing in 6-minute walk test results after ETI. Thank you for your attention.
Dr. Perron, we have a question for you that came through the iPad. Why do you believe 38% of patients with mild to moderate disease had a decrease in their 6-minute walk test? And the second part of this question is, would you assume the field test is not an adequate test to determine their true exercise capacity?
Yeah, so for people with cystic fibrosis who are in good physical condition, I think that the 6-minute walk test is not the better test for assessing exercise capacity, and maybe other tests like cycle ergometer, peak power test, or sit to stand up test can be considered.
Okay, we'll take a question, please.
Yeah, thank you. Mark McClellan at Corewell Health in Grand Rapids, Michigan. Really nice talk, very interesting. You mentioned that there doesn't seem to be a correlation between improvement in PFT and improvement in 6-minute walk test. And I was just wondering if you have any thoughts on that, because, it seems anecdotally, and we probably have all seen this, we've seen that, where there's patients who don't get a lot of benefit in terms of PFTs, but yet sometimes they feel so much better symptomatically and in terms of exercise function, and there doesn't always seem to be a correlation. So I was just wondering if you could just hypothesize, or if you speculated on what other factors might be at play that result in improvement in the walk distance or exercise tolerance that doesn't get reflected in PFTs.
I don't understand the question, sorry. Can you repeat, please?
Yeah, of course. I think if I understood you correctly, there's not a correlation between improvement in PFT and improvement in 6-minute walk, correct? Just wondering what other factors you think might be responsible for that observation. Is it a skeletal muscle or cardiovascular effects?
Maybe the patient with severe lung disease had the greatest improvement in pulmonary function, and maybe it's this patient who have the greatest reduction in thoracic hyperinflation. So maybe if we conducted the study only with patients with severe lung disease, it will maybe explain other results.
That's a good point. Maybe the static measurement of spirometry isn't good enough to find that. Thank you. Good talk.
You're welcome.
John, do you know? Okay. Another question for you, Doctor. Do you have data on the baseline walk distance for the FEV1 less than 40%? Or is the baseline for the whole group overall?
So 641 meters is the baseline for all patients. And the mean baseline for a patient with FEV1 less than 40% was around 590 meters.
We have another question. Do you have any data on the patients who had a decrease in the 6-minute walk test?
Which data? So
Which data? In regards to?
The folks that got worse, there were, I think, 8 or 10 people whose 6-minute walk distance dropped kind of dramatically, more than 50 meters. Do you know anything about those folks?
no, I don't have.
Another question. What reference equation was used for the prediction? What was your reference equation, the equation that you used to
For pulmonary function test or for 6-minute walk test? European and American Thoracic Society guidelines.
Criteria?
Yes, criteria.
criteria for the 6-minute walk test?
Yes.
Okay. And another question. Were the patients given an exercise program upon starting ETI as well?
So they don't have specifically a rehabilitation program during the study per period. Yeah. Thank you.
Our next speaker will be Dr. Brenda Button. And Dr. Button will be presenting exercise participation in association with better health, related quality of using the score, Alfred Wellness Score, test score with adults with CF.
And yes, so if you're here in the session, you've probably heard the name Dr. Budd before. You've probably heard her present here at CF conference before, but she's a senior clinical physiotherapist at Alfred Health in Australia, a frequent presenter here on airway clearance, exercise, all things physiotherapy and cystic fibrosis. So we're glad to have you back.
Thank you very much for this invitation to share with you this study on behalf of our team. I have no disclosures related to this presentation. So it's very well established that physical exercise is important in CF. I don't think I need to say a whole lot more on that as a statement. And we, about 10 years ago, the head of our physiotherapy department said, you do all this work in CF, how do we know you're actually making a difference? What outcome measures are you using for the inpatients and maybe the outpatients as well? He wanted an outcome measure for our whole department for all of our patients that were being treated by physiotherapy. The rest of our department used the ILOA score, the modified ILOA, which doesn't work for CF. And so I went to our head center director and said, what are we going to use for our patients that would be suitable? So we looked at what was in the literature, and we certainly looked at the COPD CAT score, and none of that was suitable for CF patients who were younger and fitter and much more active. So his view was, let's develop one. We need a short, quick questionnaire that can just give you an overall picture of your patient at the time. We do recognize that the CFQR is the gold standard, but it's 55 questions and it takes about 20 minutes to do, and patients don't always complete them. So it's not something you can actually use as a quick picture of the patient. So with focus groups, with the multidisciplinary team, as well as with people with CF, we set about developing the Alfred Wellness Score, which the people with CF renamed. They said that's a clunky name. Let's call it the AW score. How awesome are you today or not? So this is what the AW score looks like in a paper version. And it is a patient-reported outcome measure, which in the past was always regarded as a very soft measure. But I think in the future and even currently, PROMs, as they're called, patient outcome measures, are becoming much more accepted. And particularly in the post-ETI era, I think this has a great potential for our patients to use themselves. So far, it's been translated into French, Spanish, and Turkish. And we were given, after all of our meetings and during our focus groups, we were given the task of working out what were the main domains of wellness, and we came up with respiratory, physical, nutritional, psychosocial, which really was psychological, and general health. So for respiratory, we had to decide 2 for each domain. What were your 2 most important questions? Of course, we could have asked many other questions, but we were given 10 questions, 5 domains. So for respiratory, it was cough and sputum volume. For physical, it was energy and exercise. Nutritional was appetite and targeted weight, and that could go in both directions. It could be too low or too high. And for the psychosocial, it was mood and anxiety, and general health included sleep as well. So potentially you could score as high as 10 on each of those, and if you got 100, 10 lots of 10, that would be regarded as perfect wellness, which nobody ever scores. And this was, as I said before, the people with CF had a lot of input into this as well. So each question had an anchor. On the 0 side was the least well, and on the 10 side was the most well. So for cough amount, it would have been all the time versus hardly ever. And then for sputum volume, highest versus none at all. Energy level, exercise participation, and appetite would be lowest versus highest. And then targeted weight, either way off target, which could be too high or too low, or recommended, or what people felt was right for them. So often there was a little bit of a discussion as well, what is recommended weight? Well, it's maybe what your nutritionist is encouraging you to be, but also what do you like to be? Well, how do you feel best? Mood, lowest versus highest, most cheerful. Anxiety, high level of anxiety versus relaxed or low level. And then sleep quality and general health, poor versus excellent. So that really gives you an idea of the whole score. We found it to be reliable. We did a test, a study on reliability in the outpatient clinic where they would come in and do one first thing as they arrived, and then when they left at the end of the clinic. And the one that was done early was taken away and put away in a folder, so nobody got to see that one when the next one was done. It was shown to be valid against the CFQR, and the responsiveness was during acute exacerbations versus baseline. So we could definitely see that it was sensitive to that. The other part of the reliability was within the inpatient setting. So they did one when they were first admitted and then one 24 hours later before much would have changed from treatment. And you can see in the correlations here, they were all extremely high. 0.87 for mood was the lowest, and the others were all in the 0.9s. So very reliable, amazingly reliable. And we see that all the time with our patients coming in to clinic, how often they have almost exactly the same scores when they're at baseline. So the aims here were to use this OR score to ascertain whether exercise participation correlates with elements of wellness, and to establish its usefulness in the outpatient clinic setting and online during telehealth. And another point was that in the reliability study, we found that the average time to complete this was less than 1 minute, up to 1 minute. So you get a very quick picture, and we say to people, score yourself based on your worst and your best for each of these, read the anchors, and go off the top of your head. Don't overthink it. So here we completed the OR score either in face-to-face in the outpatient clinic, where they, as in this picture, or during telehealth reviews where we would actually ask the questions and complete that and add them up and give the patients the scores. We found it particularly useful during the COVID-19 epidemic because to begin with, it was the only outcome measure that we had from our patients where everybody was locked up at home and online. And that was until we started getting home spirometers to everybody. And from the OR scores, we often got referrals to our psychologist, particularly during the pandemic when we didn't have a lot of face-to-face contact, because a lot of these patients, or some of them, not all of them, but would score low mood or high anxiety, and we're very happy then to be referred to the psychologist, whereas in the past, they might have been the people who you might have offered the psychologist to, and they would have said, no, I don't do psychology. But having scored it themselves, they were then happy to be referred. So our psychologist was very grateful that he kept his workload coming, basically coming off these OR scores. And then after a year or so looking through all of these questionnaires, our eyes started to tell us. It seemed to look like those who were participating well in exercise had more energy, better mood, sometimes less anxiety, and better sleep. So we started asking ourselves, is there a correlation between exercise participation and these outcome measures? And on the left, you can see a typical one where exercise participation was circled as low, 3 out of 10, And mood, anxiety, and sleep amount were all less than 5 out of 10. And that was the sort of picture we were picking up and wondering whether there was a correlation there, compared to the one on the right, where everybody, all the questions were greater than 5 and nothing sort of stood out as a red flag. So we took the results of 221 adults during the year 2021. About just a little bit over half were males. This was all done during baseline stable state wellness. And this was approximately 2/3 of our clinic population. So it was a very good spread of age, 35 years, FEV1 65%, FEVC 79%, and BMI around 23. This was in the era of the early modulators. In Australia, Trikafta was not yet available. That only became available to us in 2022. So a good number, probably 80 to 90% of these patients were on one of the early modulators. So the mean scores for total was 71. And then you can see the standard deviations as well. Cough, sputum, energy, exercise were 6.5 onwards. Appetite around 8, and this probably reflects the modulators, and weight close to 8. Mood, anxiety were pretty good. And then sleep 6.8 and general health 7.2. So this just gives you a picture of the mean of the whole group. Then when we look at the correlations and the R-squared values, we see the total score was 0.51, so that was our highest correlation. Energy, 0.38, general health, 0.33, mood, 0.23, and sleep, 0.2. And then the rest of them were all below that. So here is a graph showing the total OR score, and I think one's eyes tell us as well, even though the correlation 0.5 isn't the highest, there certainly seems to be a correlation there. And then this is energy, 0.37, general health, 0.33, mood, 0.23, and sleep, 0.2. Exercise and FEV1 is what we would expect. No correlation at all, pretty much a flat line, and the same with exercise and FVC. So this brings us to the question, is it the chicken or the egg? Is it exercise participation that leads to improvements in feeling well and energy and general health and mood and sleep? Or is it because they are more well that they're exercising more well? So we can have a big discussion about that. Our future directions are that we would like to have an electronic version using something like REDCap or other. We are a little bit open. For use with people with CF at home, we've had a few of our patients who've actually set them up on their own smartphones, and they've used those to assist in identifying acute exacerbations in the post-ETR era, because often they don't have increased sputum, and it's very difficult then to pick up that they have an exacerbation. But some have noticed that their appetite is down, they're not sleeping as well, they not got as much energy, and they're exercising less. And that's often are the symptoms that tell them, maybe I'm having an exacerbation, get some blood work, or come and see us in the clinic. We'd like this to link directly with our unit record. However, we want a quick version in the clinic, because if we have a copy on the desk when each health professional comes into the room to see the patient in the outpatient clinic and can look at a quick score and then focus on their areas of questioning and interest and prescription, we might improve the clinic flow, because we know that every health professional asks all the same questions. What's your cough like? How much sputum are you getting? Are you exercising? What are you doing? Etc. And patients get annoyed with being asked the same question by everybody. And we sometimes then have health professionals crossing lanes and starting to give advice outside of their area of expertise. So we would really like to find a way to have this available, ideally electronically, but if anyone has to go looking for it on the unit record, they just won't do that. We know how things go in clinic, it's always busy. So if anyone's got good ideas about how to achieve that, that would be very beneficial. And so in conclusion, we do believe that the total OR score correlated with exercise participation, that we know exercise does lots of good things. We heard lots about it in the debate yesterday. And we think that maybe energy, general health, mood, and sleep scores may have contributed most to this correlation. So we found that use of the OR score, either face-to-face in the outpatient clinic or online with telehealth, is feasible, and it was especially useful during the COVID pandemic, which we hope we won't have for a very long time. And that's the publication of all of the psychometrics there. And we acknowledge all the people with CF who helped us develop the score and the members of the MDT, all of the members who were involved. And thank you for your attention.
Dr. Button, there is a question in the portal. Do you find a specific cutoff score for mood anxiety to trigger a referral to psychiatry or psychology?
Well, certainly less than 5 is our cutoff score for the psychologist, and then the psychologist will make the decision as to whether they need to see the psychiatrist. But that's often as anything less than 5. 5 is kind of in the middle, I'm kind of okay, but less than 5 is probably not so okay, and that's kind of where our gut feeling has gone, and that's worked well for our psychologist.
Thank you.
Thank you.
Thank you very much.
So while you're coming up to the mic, another question is, has this been used any in children yet?
Has it been used in children? I believe Hopkins. Is anyone here in the audience from the Hopkins unit? Yes. Do you want to, Holly, or one of your colleagues, do you want to come and just tell us briefly?
Yeah, sorry, super brief. We are doing it with only down to 12 right now, so children 12 and up. We just started this year. We love it. Because it's so quick, and even the kids can access that. And then, like Brenda was saying, every member of the team can look at it. But we were just trying to see if it was, again, feasible or whatever. And we have definitely adopted it. It's wonderful, but only in that population. We haven't gone down younger than 12.
Thank you, Holly. And we do wonder whether the parents could answer it in lower than that age. So that might be an interesting thing for your unit to look at. What is the parents' view, because they hear them coughing at night and etc. Maybe she's got another comment to make there. Is that microphone on?
Is it on? Can you guys hear me?
That's better.
Sorry if I wasn't talking loud enough, which I talk too loud most of the time. I would say the one thing about that, we did find some of the kids, when the parents were trying to answer the questions for them, we didn't think they were, like there was a discrepancy. So we like it when the kid can answer
Absolutely.
it more than the parents. So, but also we had one child who's developmentally delayed. So she fit into our category, and the parent was answering that. And that was like, the scores were dramatically different. And in that particular case, we thought the parent was probably more on track. So that would be an interesting thing to look at. But we did have concerns, like if the parent was doing it for even a 12 or like trying to do it for them, like, no, let them fill it out. Because sometimes they're surprised at what their kids are saying as well, but it's accurate.
And that might be interesting for them both to score it and then to have a look and see what they're thinking. It may open up some interesting conversations, especially as you're trying to get teenagers to step up and start taking more control, and parents to start, or carers to be stepping back a bit. That could be an interesting angle as well. Yes, thank you.
Hi there, Adam Loretta from University of Florida. Thank you for the presentation. I've been using the OSCOR, and it's been awesome.
Sorry, and you were from?
University of Florida. So the one thing that I've noticed with it is the first 2 questions. I have anecdotally a lot of patients when they're filling it out, they actually fill it out backwards.
Yes, and you have to just check with them. If it doesn't look right, we've only found the one that they sometimes, you've got to really explain to them 0 is your worst of always on all of them, and 10 is your best.
And and part of that is more just kind of the clinic flow. So whenever I'm using it in the outpatient setting. So it's part of the intake process. So I'm not there whenever it's delivered.
Right.
And during the evaluation, I go over it and I notice and I say, hey, this looks like
is
this
this
is off.
correct?
And
Exactly.
it's fine. But my concern is if we do it electronically and we're not there, they're filling it out at home. And then that's being used in REDCap for data that may throw off some of the.
That's an interesting point. And I think we'll always want to have a conversation. I don't think you would just be having them doing it and it just going into a record and not having any conversation. Because the one on anxiety, sometimes they just switch that by mistake because they think I have no anxiety, so it's a 0 or
Right.
down the low end. And then you say, oh no, can we just clarify this? Have you scored this correctly? And sometimes it is yes, I'm having a lot of anxiety, but sometimes it's no. Oops, I've switched it over. So thank you for those are good points. Thank you.
So I have two questions. One is, how frequently do you administer the OS score? Is it annually, or if there is any significant, like if patients are scoring like on from 0 to 5 on the lower side, do you give out more frequently, like quarterly?
We would often use it in the outpatient clinic when they come in and just do it first off, if possible, at the beginning. We as the physiotherapists have been driving this up to now, but it's been taken up by the whole team and we're still working out what's the best way, most efficient way to do it. Look, it's a little bit ad hoc, but we would do it usually when they come to the outpatient clinic and sometimes when they come into hospital and then when they're going home. When we were doing all the studies, it was much more consistently done, beginning of admission, 24 hours, end of admission. But I think you can use it any way you want to. And certainly whenever we are doing studies, we always do an OS score as well, because that then gives us more chance to link it, say, if we're doing the CFQR, to look at validity and so on. So I think it's whatever you want to do with it. And different units are doing it in different ways. Hopkins, how often are you doing it? Every time you see them in clinic as an outpatient. Thank you.
One more question. I noticed among the 221 patients, the mean was around 64. Did you have any severe or advanced lung disease
Sorry, when which,
for FEV1?
we had that right across the range. It was 2/3 of our clinic.
Okay.
So we would have had people with very low lung function all the way through, but a lot of these would have, probably 90% of them would have been on the earlier modulators, but no, it was right across the range.
Okay. Thank you.
So there would have been some with really low lung function in there as well, but some with very high lung function.
Just wanted to comment, it's a brilliant thing that you're so right in terms of patients don't have time. Sometimes even that 2-minute, or even when we do a 1-minute sit to stand, is a lot for them. They're always in a rush, especially since they're feeling better with the ETI. So this is brilliant that it's short, it's fast, and it's very relevant. Few questions and targeted to pick out like those 5 things for their health. So
Thank you very much. And the other comment from when we first started using it was they loved this as a questionnaire because it focused on wellness. And they often commented all of the other older questionnaires have focused on symptoms and disease. But even if they're not feeling well, they still like the idea that this is focused on wellness.
So I'm going to switch it around and ask a question for the audience. So we know Johns Hopkins just mentioned that they use it, University of Florida. How many other, just show of hands, other folks that are using this? Okay.
Where are you from?
Actually recently. I'm from St. John Jameson, so from Canada.
Canada.
Syracuse, New York.
Syracuse, New York. Right. Excellent. Yes.
Northern Virginia.
Lovely. So quite a spread.
Who plans on using it after listening to this talk?
I'm very happy to be emailed, and I can send you all the publications and all the bits and pieces that go with it. So my email address is on my presentation, I believe.
There's a few more questions that have come through the portal. Dr. Button, other than mental health component, are you interviewing on any other factors encouraging low moods to exercise?
Absolutely. In fact, we often will look at that. If their exercise is low, they're not sleeping well, that'll be the first thing we'll say. Do you think if you if exercise was more part of your regime, do you think you might sleep better? Maybe we should try that out. Try it a week about, something like that. So yes, absolutely, exercise is a big factor for us as physiotherapists.
Have you identified a MCID?
No, we haven't. We haven't done that yet. When we actually did the reliability study, we found that a difference of 14 points was significant. So if you know more or less what their baseline usually is and they 14 or more points lower, they may well, that may be significant. So that's all we know to date.
Do you think normative values are possible? Quartiles, reference values?
Oh, that's an interesting thought because, you're talking about the feeling of wellness, and what we have found is that you can have very low lung function, but when you're at baseline, you can feel very well because these people acclimatize to what's happening. So I'm not sure whether that would be a very useful thing to do or whether it would be possible, like with lung function, for example. But that's a good thought, something to go home and think about.
Do you hypothesize that the nutrition scores would have been lower in a pre-modulator era?
Oh, absolutely. And in fact, we should probably go back and look at that. It would be interesting
yes.
for appetite and for targeted weight, because I think a lot of them would have had really high scores. In other words, were happy with their weight. Particularly the women love being slim and they hate having put on 5 or 10 kilograms. So I think that would be a very interesting thing for us to go back and do. Thank you.
Very much so. One last one. Do you think this would work with the FACES type score for younger children, like how we evaluate pain with the Baker-Wong FACES?
Ooh, that's a good question.
That's a good one, yeah.
Yeah, no, I couldn't give an opinion.
Yeah, thank you.
Thank you.
And just some feedback. I noticed you were saying correlation during your presentation, but you were reporting the R-squared values, which makes them look a little bit lower. So
Yeah.
when it comes time to publish, you might want
Do
to
it,
report the R instead. I don't know. Talk to a biostatistician.
that's
I'm
a
not.
good
I'm not that
point.
bright with biostats. But
No, that's certainly a good point.
One more question?
Hi. So 14 for the total score was significant. Did you find any significant change in score for the individual categories?
Can you say that again?
So the change of 14 was significant for the total score. In the individual categories, did you find any significant change within the 10 of each category?
I think it probably also came from looking at when they were in exacerbation, because we had a whole group early on before the modulators. We've been doing this for over the last 10 years, where we had when they were in exacerbation versus when they were at baseline. And I think that's really where that data came from. But we probably need to relook at all of that post-ETI as well.
Yeah, just curious of if you're looking at exercise or mood specifically. Maybe they didn't change on anything else, but maybe.
Okay, no, we haven't looked at that.
I don't know.
But that would
7
be a
one
good
time,
point
3 or whatever.
to see that. Thank you, that's a good point. Thank you.
Thank you, Dr. Button.
Thank
This
you
was
very much for your
wonderful.
time.
Thank you. Our next presenter is Caitlin Preston, and Caitlin will be presenting feasibility and reliability of the YMCA 3-minute step test in adults with cystic fibrosis. Welcome, Caitlin and John. A little bit of background on this.
yes. So this is welcome, Caitlin, presenting at NACFC for the first time. She's a physical therapist at Butterworth Hospital. Got her DPT at Grand Valley State University 2019, completed a cardiovascular and pulmonary residency program, and is board certified in cardiovascular and pulmonary physical therapy. And so welcome.
Thanks. I come from the Corewell Health West Cystic Fibrosis Clinic in Grand Rapids, Michigan. So we were looking at the feasibility and reliability of the 3-minute step test, specifically the YMCA 3-minute step test. I have no relationships to disclose related to this presentation. So as we all know, regular exercise testing is recommended for patients with CF and is considered a standard of care. So ideally, we are all completing some form of exercise testing in our clinics to monitor decline and look at function and disease progression. The gold standard would be cardiopulmonary exercise testing, or CPET. However, field testing, as we often do in clinic, is important between CPETs or when it's unavailable or just not feasible for our patients for various reasons, including cost and just ability to complete with needing supervision, et cetera, for CPET. When we do field tests, and when I've done field tests in the clinic, I often find that field testing without external pacing is really limiting for my patients because they don't necessarily always put forth the same amount of effort or motivation, and it can be really variable from time to time depending on that motivation they have day to day or effort they put forth, or just between each individual I see. And so we were looking for, what tests can we do, use as external pacing that is really efficient to do in clinic. And so we looked at the 3-minute step test, which has been used a lot in submaximalist testing and looked at in multiple papers in CF exercise testing. However, this has primarily been researched in children, and that test was actually reduced to a 6-inch step, understandably, because children are shorter, right? Originally, it was a 12-inch step. The only test looking or study looking at the 3-minute step test in adults was by Holland and authors. And they found that 77% of moderate to severe lung function reached peak heart rate, and then 42% of mild severity reached peak heart rate. And then they did find that if you desaturated below 90%, it demonstrated increased hospitalizations and greater decline in that FEV1. They did not, in this study, look at test-retest reliability of the 3-minute step test, and they did use a reduced 6-inch step in this study. So there really has been no studies since ETI therapy on the 3-minute step test in adults or adolescents. And so this just opened an opportunity to say, how are we looking at the 3-minute step test in this era of ETI therapy? So what was our purpose? We were starting with just looking at, what's the feasibility, what's the test-retest reliability for the YMCA 3-minute step test in adult patients in our CF clinic, which 87% are on ETI therapy at this time. And then we were going to look at the associations between peak heart rate recovery, blood pressure, oxygen saturation, perceived exertion responsive, so RPE, and we are using the Borg 6 to 20 scale. And then also looking at clinical characteristics and health-related quality of life using the CFQR. So we use the 3-minute step test, the YMCA. This step test is a 3-minute test. They use a 12-inch step, so if a standard height step is 8 inches, right, it's 4 inches higher than that. And you're gonna set the metronome to 96 beats per minute or 24 steps per minute. They're gonna step on and off that step to that pace of the metronome for those 3 minutes. And if they go off that pace, you encourage them to get back on the pace, or you end the test at that point because they're not maintaining that pace. That does not matter which foot they lead with or if that changes during the test. Our inclusion criteria was anyone with a diagnosis of CF and that they're greater than 18 years old, that they're at least clinically stable for the last 2 weeks without signs or symptoms of exacerbation. That was assessed either by the physical therapist or physician that day. And then that they're able to step up onto that 12-inch step 5 times just to make sure that there's no strength limitations to completing that 12-inch height since it is an elevated height. We excluded anyone with heart rate blunting medications like beta blockers or calcium channel blockers because one of our outcomes was heart rate, and so we didn't want that influencing our results. Exclude anyone with possibility of currently being pregnant just via verbal screening. Frequent falls defined as greater than 3 falls in the last 6 months, and then anyone with a history of lung transplant, coronary artery disease, pulmonary hypertension, arrhythmia, or very severe obstructive disease, which we defined as less than 40% FEV1, and that was just to kind of exclude out other things that might be impacting our results. Use of supplemental oxygen, and then any history of neurological disease or musculoskeletal problems that impacts their ability to climb stairs. So what did we do? We gave all of our patients the CFQR to use quality of life mechanism. Then we administered the first 3-minute step test to a patient. They then waited at least 30 minutes. This was during their normal clinic visit, so then they would see other healthcare providers during that time. And then after those 30 minutes elapsed, depending on the patient, it might be longer, depending on clinicians were working with them at the time. We completed a second 3-minute step test. And then we concluded the study when they returned to their resting vital signs. We looked at heart rate, we looked at systolic and diastolic blood pressure, RPE, which was the 6 to 20 Borg scale, and then oxygen saturation. Heart rate and oxygen saturation we did continuously throughout the test. Blood pressure and RPE we looked at pre, post, and then 1-minute recovery, and then as much as we needed to get to resting state vitals. How did we determine feasibility? So we looked at percentage of our interested patients, so patients that agreed to participate, that were able to perform at least 5 step-ups onto that 12-inch step. We looked at percent of patients who were able to complete the entire 3-minute step test. And then we looked at how long this took, because for all of us, it really matters, how long are we gonna spend doing this test in clinic? Test-retest reliability, we looked at the interclass correlation coefficients of peak heart rate as a percentage of heart rate maximum and recovery heart rate. And then we also looked at Pearson correlation coefficients to examine associations between peak heart rate as a percent of heart rate max, heart rate recovery, blood pressure, oxygen saturation, RPE, and CFQR scores. So what did we find? So we had 151 of our 198 patients who were eligible for the study. Unfortunately, only 114 weren't approached or declined to participate, and a lot of that was due to time constraints because we were doing this on top of my normal clinic, and I'm the only physical therapist at our facility, at our site. So we had 36 adult subjects who we were able to enroll in our study. This is our demographics. Things that I would point out is our median age was 29. We didn't have any ethnic diversity, with 100% being white or Caucasian, which is consistent with our population. And then we did have a generally high or healthy group of participants, and I just want to point that out because that will impact the generalizability of this study. So that is a 95% is our mean FEV1. So 100% of our studies were able to do the 5 step-ups onto the 12-inch step, so that we didn't have those strength limitations with those who agreed to participate. Of the 36, about 14% or 5 of them were unable to complete the first test. That was due to a couple reasons. Most were actually like knee pain or some sort of strength issue with like their quads or glutes. The other ones were pacing, and then one person we had to stop because of just an elevated heart rate response in the middle of that test. One person was not able to complete the second test, and it was just due to a scheduling conflict. They needed to leave, so they weren't able to be included in the second test data. Test-retest reliability, we found that the test took about 10 minutes to complete, which was very reasonable to us to complete within a clinic time frame, and that the mean rest time between tests was 41 minutes. So it's about how long we were resting between completing the test-retest reliability. We did find that we had excellent test-retest reliability. If you look at the ICCs, you can see with peak heart rate, we had a 0.95, peak heart rate as a percentage of heart rate max was 0.95, and recovery heart rate was 0.91, showing excellent test-retest reliability. This is showing you the physiologic responses, so you can kind of see that as you look from the side, from one side to the other. So resting heart rate was a mean of 77 on test 1 and a mean of 80.6 on test 2. And then peak heart rate 145.6 on test 1, 147.8 on test 2. There is a general trend to be a little bit higher on test 2, and so we do have some question of whether they needed maybe a little bit longer rest break between those 2 tests to really come down to physiological norm, which could be considered in the future. So our preliminary data suggests that the YMCA 3-minute step test is feasible. It's externally paced, allowing for consistent patient effort between clinic visits. The metronome pace for most patients is feasible, and it's relatively short to complete. It was also able to be completed in the clinic room, which helps prevent cross-exposure from our CF patients to each other, where like 6-minute walk tests, we have to go out into the hallway to complete, and just requires a little bit more coordination. 5 patients were unable to complete the test because of musculoskeletal or strength deficits, which just puts in the consideration that we need to consider who are we doing this with, and there might not always be the right test for certain patients depending on what their deficits are. Test-retest reliability, we found that that's excellent test-retest reliability for peak heart rate as at 1-minute recovery, and heart rate as percentage of max. And then we do have the minimally detectable change of 11 beats per minute for peak heart rate, 5.7 of percentage of heart rate max, and heart rate at 1 minute recovery as reducing by 15 beats per minute. Limitations of our study. So we had a really small sample size. So in the future, we'd really like to look at this as in a larger sample size, so it's a little more generalizable. Generally healthy CF patients, right? So we can't generalize it across all of our CF patients. We're lacking ethnic diversity. And then the majority of our patients were on ATI therapy. We did look at separating those two groups, but we didn't have a huge significant difference between them when we did separate them, which is why we combined them together. It was a fixed 12-inch step, so we didn't adjust that for height, and so that is something to consider. If you have a patient who is shorter, it's going to be a larger workload for them to step up on that 12-inch step, where if someone's taller, that's going to be easier to complete. And then only that 30-minute rest time, so that could have limited their ability to come down to truly physiologic resting before completing that second test. So generally, we can say that the YMCA 3-minute step test may be a feasible and reliable test. We do need more research to determine that for sure. Minimal time to complete, able to complete in a standard exam room. And then you really need to consider knee pain and pace of test, that this may be a limitation for some of your patients to determine if this is the right test to use for them. But there is ability to potentially detect short-term clinical changes. We didn't do this over a long time frame, so there are changes from day to day and week to week that could impact this. And so further research needs to be done on these data points to determine if this is going to be responsive over time for changes in aerobic fitness and clinical status. Also, just further investigation of feasibility with a larger sample size, and then to determine if there is concurrent validity with that cardiopulmonary exercise test to determine aerobic fitness over time. And that is all I have. If there's any questions.
Nice job. Thank you. Welcome. Yes. There is a question in the portal. What was the reason to exclude patients on supplemental oxygen? Did you have any?
If I remember back, part of it was getting it through our IRB, and because we hadn't done an exercise study like this, we were trying to keep it a relatively healthy sample size, so that our IRB was accepting of going through this exercise testing process in the initial testing.
Next question.
Oh, thanks. Hi. First of all, great study. I use this in my clinic all the time, so I was really excited that you were doing all the same things that I was doing. Do you ever look at like the norm values just for the general population, or are you more looking at like recovery from like their last clinic visit to this time?
I haven't fully instituted it into clinic yet.
Okay.
I find that the normative data is kind of interesting. If you know the YMCA 3-minute step test, it's actually a heartbeat count that they're looking at. And so it's supposed to be, if you finish it, you count the heartbeat count from when you finish in that 1 minute, which isn't super utilized anymore in how we use things. And so I would look at heart rate recovery would be my
Like look at the heart rate like a minute after and see what that's like.
and see what it's at.
Okay, thank you.
Yeah.
There's another question. I love this test, but struggle to find pediatric norms. Any suggestions? Any insight?
Unfortunately, I focus mostly on the adult population, so I haven't looked into where the pediatric norms are. So I would have to do more research to find that.
Okay. And another one. The MDC is a change signifying what? Improved or decreased cardiovascular health?
We don't necessarily know the answer to that because we'd have to look at it and correlate it right to more data. We know that that's just the minimally detectable change, but based on the data that we have present. But I can't necessarily connect it directly to cardiovascular health because we didn't look at that.
This is just kind of a methodology question, but how did you, were they wearing a heart rate monitor or how was heart rate assessed?
We used a polar heart rate monitor.
Okay. And I noticed on one of your slides, you talked about the number of patients that didn't complete the test, and you said not approached or declined. That's kind of a big difference between they refused to do the test versus you didn't approach them. Do you have any idea as to how many of those actually did decline?
We didn't collect that specific data set, so I don't have data on this is who we didn't approach versus this is how many declined. There was quite a few who we didn't approach, and there's a lot of people who kind of soft declined who would say, well, I don't want to do it today, but next visit I'm going to do it. And so it's hard to kind of keep track of who's declining and truly declining. I'm not going to do it at all.
I was wondering, with pregnancy, if there's a specific reason why we're excluding those women, if they're having like uncomplicated pregnancies. I feel with ETIs, there's a big uptick in pregnant women. I feel like I'm doing them a bit of a disservice by not being able to exercise test them. And if you found anything along those lines.
I don't have anything along those lines to go with. This was just our protocol for this testing just because of current research and how we, but it is something we should definitely look at in the future, especially with current recommendations. Yeah.
One more question in the chat. So you mentioned that one or more patients, you stopped the test due to a heart rate response. What was the threshold used to terminate the test?
We had one patient who we stopped during a heart rate response, and I don't have the data right off the top of my head, but they were like pushing 90% of max heart rate, and so that was the point at which I decided they should terminate the test.
And so now, I guess I'll ask another question for the audience based on the last one. How many of you, I've heard a couple of you say you use the 3-minute step test. How many, just a raise of hands? Okay. And I guess back to our first presenter, how many use the 6-minute walk test routinely with your patients? Okay, great.
Thank you.
Thank you.
Great job. Moving on, our next presenter is Renale Arsinas, and she will be presenting quantifying physical activity in children with cystic fibrosis in the era of highly effective modulator therapy. Welcome, Renale.
Yes, welcome back, Renali. Renali got her Doctor of Physical Therapy degree in 2003 from New York Institute of Technology. She's kind of a veteran here. She's been doing cystic fibrosis care since 2016. She's currently physical therapist in the outpatient clinic at Children's Health Center in Dallas, Texas. And she was in part of the mentoring program and has presented a few times at NACFC. So welcome back.
Hi. Okay, so hello, my name is Renali Arsinas, and I'm a PT at the CF Center in Children's Health in Dallas, Texas. This presentation is based on a QI project I started in 2021, and the specific poster number is 528. Okay, I have no relationships to disclose related to this presentation. So a little bit about our center. It's a pediatric center, and we currently have 258 patients. We have two co-directors, Dr. Preeti Sharma is our pulmonologist, Dr. Meg Sate, our gastroenterologist. Our program coordinator is our nurse practitioner, Preeti Varghese. And in addition, on our team, we also have an endocrinologist and an infectious disease doctors. Our support disciplines consist of social work, RTs, dietitians, psych, research coordinators, and medical assistants. On the inpatient side, we also have child life and pharmacy. Did I miss it? Okay, got it. Okay. So here's a quick review of the modulator therapy timeline. When I joined our team in 2016, Kalydeco and Orkambi were the modulator therapies that have been approved by the FDA. At this time, most of my referrals, besides annual assessments, were patients who were considered to have advanced lung disease with FEV1 under 60%, or those we placed on what we called our watcher list. And these patients had downward trending lung functions, mostly from 80% to 60%. However, with the approval of Symdeko in 2018, and especially Trikafta in 2019, the medical presentation of my patients changed dramatically. On this slide shows our center data from 2016 to 2023. The purple line that spiked up in 2019 represents the percentage of Trikafta use in eligible patients at our center. And then on the top of the graph, the dark blue line represents median FEV1 of patients between the ages of 6 to 12 years old. And the orange line represents the median FEV1 of patients ages 12 to 17 years old. So as you can see, the FEV1 after Trikafta was initiated is in both these age groups increased. On the bottom of my graph, sorry, I'm looking at my talking points. On the bottom of my graph, you can, the green line represents the number of pulmonary exacerbations in our patients less than 18 years old, which shows a decrease from 2016 to 2023. And the light blue line represents the number of nights of hospitalization stay, which did not change much as we have a pretty diverse population of kiddos. And there are quite a few that we have that are not eligible for modulator therapy. So with these positive changes, I've had to adapt and shift my focus as a PT. Prior to Trikafta, the majority of my referrals were those patients needing pulmonary rehabilitation because decreasing lung function or multiple exacerbations. Post-Trikafta, most of my referrals were for annual assessments. So in addition, when I assessed their aerobic capacity, the 6-minute walk test or the 3-minute step test no longer was suitable test to administer. They had a higher tolerance to exercise, and therefore the self-paced 6-minute walk test did not accurately test their submax exercise capabilities. And the 3-minute step test, while able to attain submax heart rates, I could tell they were not reaching the exercise intensities of moderate to vigorous exercise levels that we often recommend to these children to stay healthy. So I had to shift my focus to promoting the healthy lifestyle with people with CF during these annual assessments by first finding out their current exercise regimen, and then second, what their barriers are to adhere to CF recommendations of exercising in that intensity levels for 60 minutes a day. And with this, I can recommend an individualized plan of care to help them improve and or maintain their quality of life. So what I found was when I was educating patients and their families about the importance of physical activity, I found that they all understood its benefits. You know, we know that it improves aerobic capacity, improves nutritional status, it improved their bone density, and it reduced severity of their disease. They all understood that concept. However, when I asked them to describe their current exercise regimen, I found a few problems. The majority of our patients did understand what physical activity means, so when our providers would ask them if they were active, they would say yes. But when I would see them and ask specifics of their regimen, the answers never matched our recommendation of moderate to vigorous intensities. And some of the examples I got, some of the answers I got, for example, were they were moderately exercising is what they called it, but really what they were doing was walking all day at school and able to walk from class to class without getting tired, short of breath, within the time limit that they're supposed to get to class, and not needing oxygen. Other times it was I play often with my younger siblings and we wrestle, but it's only like a time of 2 to 5 minutes and then I have to rest. So there's a big discrepancy in what they understand as what physical activity is in what we recommend in that intensity versus what we're hoping that they exercise in to keep their wellness. So this certainly isn't their fault, but mine completely. The rapid changes in both inhaled and modulator therapy in the past years have been so dramatic that I fail to show my patients that they are capable of doing so much more. So how do I help them understand what high levels of PA, high levels of PA is? So trying to put a number on something that's a really difficult concept even for adults to understand is I feel hard even for children, especially for children. So I kind of took a look at what could I do to get an understanding of what their daily life is like and across and whether it was habitual or whether it was just kind of, their exercise was just kind of once a month or something like that. So I ended up finding the physical activity questionnaire given by the World Health Organization. And in the pediatric version, there are actually 2 versions, and it's based off their grade or age. So the PAQC is approximately grades 4 through 8, with ages between 8 and 14 years old. The PAQA are ages 9 to 12, no, grades 9 to 12, approximately aged 14 to 20 years old. The score of 1 equates to a low PA level, and a score of 5 equates to a high PA level. The advantages of this survey is that it's pretty easy to administer. It's only 3 pages, but within that 3 pages, it's really only 8 to 9 questions, depending on the version that you give them. The limitations to this survey is that it has to be done during the school year. The questions are modeled after what you would do in a day during your school. So, for example, are you in PE, and during your physical education class, how often are you active? So, if it's summertime and you're not in school, then this is a question that's not appropriate. So that. All right. So when I was finally able to kind of iron out my process for the QI project, I was able to test 25 individuals from December 2023 through the end of March 2024. After the questionnaire was given, the exercise test I chose to use was the Bruce treadmill protocol based off the 2001 research article by Wessel, providing normative values for children ages 4 to 18 years old. Bruce treadmill protocol and how we used it was a field test for us because I only measured O2 saturations and heart rate. And I used a hospital-grade finger pulse oximeter. And the test was ended when they reached 85% of heart rate max, or if they desaturated under 90%, or if they really were breathless, your modified Borg, they were breathless and couldn't keep up with the treadmill. With the original study, they didn't allow the patients to hold the bar, but for me and safety reasons, I did allow them to hold the bar, but I watched their pace. If they were using it to keep up with the treadmill, then the test ended at that point. But if they were using it because with the Bruce treadmill, every 3 minutes, the stage changes and the parameters changes and the incline goes pretty high and the speed goes faster, then if they just really can't, that's the time that I tell them really to go ahead and hold on because of the change in speed and the change in incline. There were quite a few that were able to, obviously they were older, but that were able to do it without having to hold on. So just food for thought for how do you want to keep your kids safe. Okay. Their total time tolerated, I compared it to the normative values to determine their cardiorespiratory fitness level. And on this normative value page, there was an original study in 1978, and Wessel decided to redo it because of that was a long time ago, and he did it back in 2001, and they had to consider the increase in BMI in children and how much lower they are able to tolerate the test in time. Okay, so results, a total of 25 patients completed the questionnaire and underwent the exercise testing using the Bruce treadmill protocol. 5 patient results were not included because they were ineligible for Trikafta or any of the modulator therapy, and 1 refused modulator because they just didn't want to do it. Of the remaining 20, 35% with reported their PA levels matched the actual CRF level, which is nice. 30% performed higher with their actual CRF level than what they perceived, what they self-reported, and then 35% perceived the PA level to be lower than the actual CRF level. This is our patient demographics. Out of the 20 patients, there were 11 males and 9 females. The youngest was age 9, the oldest was 18. Everyone was on Trikafta except one on Kalydeco, and then that just, the last two columns show what their PAQ level was and their CRF percentile. So conclusions for the QI project, the survey and exercise testing results were widely accepted by the families tested. For patients whose CRF level was higher than what they reported, the results motivated them to continue their regular PA regimen without doubt of intensity or frequency. And then for patients who scored a lower CRF level than what they self-reported, I was able to set more attainable goals for them and educate on appropriate PA level, including the frequency and intensity in that whole education. So in conclusion, comparing the perceived and actual PA via survey and exercise testing is a great way to start the conversation of engaging in healthy lifestyles. It also proved the importance of us PTs in administering individualized exercise plans to improve activity tolerance and quality of life. So I'd like to just thank our patients at Children's Health for having patience with me, because I went through several exercise tests with them until I found one that suited us. And these are my references. And any questions?
So, how many? You said you stopped. You ended the test when folks got to 85% of their age predicted max heart rate. How many patients did you have to end it based on that heart rate versus they self-selected to end the test?
In this one, I believe there were two that I had to end the test because they were just saying they were too tired and they were breathless. None of them had a desaturation, but almost every single one of them, all the others reached 85% heart rate.
And so, since you're using the CPET, the exercise test, to then kind of guide prescription, and oftentimes we do kind of exercise intensity based on their max heart rate, but you stopped them before they got to their max heart rate. So we don't really know, was their max heart rate more than they're predicted? Was it less than they're predicted? And so I know, I mean, I'm kind of picking on you here, but I think oftentimes we do that. We stop people before they get too high, but then we don't know what their max is. And so we make a prescription based off an equation as opposed to the individual. So I don't know if that's more of a question or a comment, but.
Well, so there are a few times when I noticed that they were doing pretty well athletically, and I let them go towards their max heart rate. But when I knew that they were struggling, I went ahead and stopped it at 84% because I think they were just wanting to go further because they wanted to go longer on the test, but I knew that they just couldn't. However, moving forward, I should look into more of that and see how they would do if I didn't stop them and just stopped at the max heart rate.
Well, I think using your gut is a good idea too. You know, that's a reasonable explanation.
This concludes our session. Thank you all for coming.
Thank you.
Look forward to seeing you next year.